This is Susan Panter. Today we're going to be talking about alterations in ingestion, digestion, absorption, and elimination for our NURS 2244 course, Multi-System Disorders. So our priority concepts associated with gastrointestinal system include nutrition and elimination. Of course, there are many others, such as acid-base imbalances and fluid and electrolyte imbalances. So you're going to see a lot of other concepts associated with it also. And here's a quick look at the gastrointestinal system from the mouth to the anus and all of the organs in between. Our main functions of the GI tract include digestion of food, alteration or absorption of the nutrients, elimination of the waste, and then other functions would include our secretions of the digestive enzymes and the motility of the GI contents throughout the system. The liver and the pancreas are two of the organs that aid in our GI system's digestion and elimination, and we're mainly going to focus on the liver today. And taking a look at the pancreas, you're going to know that it, or see that it sits below the liver, and the liver actually has the common bile duct that goes through the liver and also to the gallbladder and then to the pancreas itself and ends up in the duodenum. So that's how all of that system is connected. So the functions of our pancreas have both exocrine and endocrine functions, and you'll notice with the exocrine functions it helps digest carbohydrates, fats, and proteins, and the secretion enzymes that help with that are the trypsin, chymotrypsin, amylase, and lipase. And then our endocrine functions are essential for the metabolic regulation. So those are the alpha cells that produce the glucagon and the beta cells that produce the insulin to help with homeostasis of our blood sugars. A quick look at the liver. It is broken down into the right lobe, which is larger than the left lobe. It has the hepatic artery, a portal vein, a bile duct, and the gallbladder that sits behind it that aids in storing the bile for our digestion. So our liver has over 400 functions, but three main categories that we're going to be taking a look at today include the storage, the protection, and the metabolism. Our liver stores minerals and vitamins such as iron, magnesium, and then our fat-soluble vitamins A, D, E, and K. And our liver also stores the glycogen that we need for our energy. One of the major functions of the liver is protection of our body. It engulfs harmful bacteria that cause our infections. It also engulfs anemic red blood cells, or the red blood cells that are not carrying enough oxygen to help with tissue perfusion. Also, the liver will detoxify potential and harmful compounds such as drugs, chemicals, and alcohol, and that's why it's so important for our liver to be a functioning liver. So how does the liver metabolize and synthesize? Well, it metabolizes by breaking down amino acids to remove the ammonia, which is broken down into urea and excreted by the kidneys. And then for synthesis, we have plasma proteins such as our albumin, prothrombin, and fibrinogen, and we know that the albumin helps with the regulation of water or fluid shifts from the cell to the vascular itself, and then the prothrombin and fibrinogen help with our clotting times. So, and then lastly on our list is fatty acids and triglycerides. It helps break that down. So what does the liver make? We talked a little bit about this already. It does produce the bile for the breakdown of fats. Remember, it's made in the liver. However, our bile is stored in the gallbladder for use as on needed basis, or as needed basis. So as part of our nursing care, taking a history of the gastrointestinal system is very important. We need to determine events that are related to the current health problem. We'll want to focus on appetite. Do we see any changes in the appetite? How about the weight? Are we seeing increases or decreases in our weight? And then stools, we want to know if the stools are a normal color, or are we seeing steatorrhea stools, which are tan in color that denote that there's fatty contents in that, or are our stools hemocult with blood in them that can denote bleeding? We also want to ask about previous GI disorders, abdominal surgeries that they may have had, pay special attention to medication, whether it's prescription or over-the-counter medication, but there are several over-the-counter medication that can cause issues, such as our herbal supplements. They can cause, or can affect the appetite, I should say. They can affect absorption and elimination. Aspirin and NSAIDs both can lead to GI bleeding. Laxative and enemas can lead to dependence and result in constipation and electrolyte imbalances. And then Tylenol or acetaminophen is one of those really important medications you need to remember, because it is broken down by the liver, so a functioning liver is important if a patient takes in Tylenol. Other things we're going to look at would be smoking and tobacco use. Travel, have they traveled out of the country that potentially could have caused some kind of a bacterial infection? And then looking at nutrition, are patients on special diets that it could affect overall nutritional status, any food allergies? Maybe we might want to ask about usual foods they eat, or how many meals they eat a day, how well are their dietary needs being met, and do they have a socioeconomic status that affects the quality of food that they are intaking. Also, we want to look at family history and then culture. So, just kind of identify what specific things can affect the liver mainly. And so, you have some cultures that maybe are big into piercings, tattoos, and things like that that might lead to some kind of a hepatic problem. So there are some gastrointestinal changes that are associated with aging. Changes in digestion and elimination can affect nutrition. Decreased gastric hydrochloric acid can lead to decreased absorption of essential minerals such as iron. Decreased lipase will result in a decrease in fat absorption, a decrease in protein and cholesterol synthesis, and a decrease in liver activity depresses metabolic metabolism, which then can lead to the accumulation of drugs to toxic levels. So things like pain, changes in bowel habits, and changes in our skin are things that are associated with gastrointestinal system changes or overall health of our gastrointestinal system. Your book talks about the PQRST, mnemonic for pain. So we need to find out what is precipitating the pain, what makes it better. We want to know the quality and the quantity of the pain, the region or the radiation of the pain, severity on our scale of 0 to 10 with descriptors, and then the timing. So when is this pain occurring? The other thing we're going to be looking at will be the changes in bowel habits. So COCA, color, odor, consistency, and amount, you want to note that on the stools. We also want to know the pattern and the frequency of the stool. Other things, changes in the skin, and again, that one is going to be directly related to our liver. So we may see things like rashes, itching, a yellow discoloration or jaundice, bruising, and also see increased bleeding tendencies. So these are things specifically related to our liver. So this slide has nothing new. You're used to the inspection, auscultation, percussion, and palpation of our good physical assessment. So when we look at our gastrointestinal system, we're going to be looking at some of those things that we talked about with the skin changes, looking for rashes and itching, looking for petechiae, looking for yellow discoloration, not only of the skin, but also of the sclera itself. We're going to be auscultating or listening. We want to know what does the bowel pattern sound like, and we also want to know percussion. Are we hearing dull or timpani sounds, meaning dull, a full organ, or timpani, meaning air in that? And I know we don't use a lot of percussion, but that is definitely one of the methods that you can use for assessment of our gastrointestinal system and the liver especially. And then palpating, wanting to know, is it within the normal borders? Do we have any tenderness? Do we have any firmness? And so those are some of the things that you're going to be looking for. So some disease processes that we're going to be looking at specifically that deal with the liver will be cirrhosis, hepatitis, and liver cancers. So cirrhosis is an extensive, irreversible scarring of the liver. It's caused by chronic reaction to inflammation and necrosis. It does develop slowly, but it will progress with prolonged destruction, and also it will result in end-stage liver disease. So we'll discuss the types and causes of cirrhosis. There are 3 types listed in your book. Post-necrotic is caused by viral hepatitis or medications and toxins. Lennox is caused by alcohol use disorder, and then biliary is caused by biliary obstruction or autoimmune disease. So things like that might be if we have gallbladder issues and we have bile ducts that are obstructed. So our causes would include chronic alcoholism, chronic viral hepatitis, non-alcoholic steatohepatitis, or the book calls it NASH, bile duct disease, drugs and chemical toxins, and then also you can have a genetic factor that can cause cirrhosis. The pathophysiology of cirrhosis includes fibrotic scarring, inflammation that causes extensive degeneration and destruction of our hepatocytes, which are the hepatitis cells. We'll have nodules that develop, blocking bile ducts and blocking the blood flow. The liver will become enlarged and firm in the early part of the disease state, but as the disease progresses, we'll see the liver shrinking and decreased function of our liver. Signs and symptoms of cirrhosis include fatigue, weight loss, abdominal pain, abdominal distension, confusion and mental changes, personality changes, astrixis, which is what they call a liver flapping tremor. The hand, when you extend the hand and the wrist, you'll see a tremor of the hand. And then Factor hepaticus, which is a fruity or a musty odor to our breath. So there are some complications of cirrhosis that can be either compensatory or decompensated. So if we have compensated cirrhosis, we have scarring, but the liver is still functioning. If we have decompensated cirrhosis, the functioning of the liver is definitely impaired. And there's some different disease processes that can occur as complications: portal hypertension, ascites, and esophageal varices, coagulation deficits or defects, jaundice, portal system encephalopathy with hepatic coma, and then hepatorenal syndrome and bacterial peritonitis. And you can see I have 3 of them that have little tablets by them: the portal hypertension, ascites, esophageal varices, and then the portal systemic encephalopathy with hepatic coma. Those are topics that we're going to discuss in this presentation. And this slide just shows some of the lab changes that you're going to see. Many of the labs are elevated, especially your liver enzymes, but some of the things I want to point out would be like your protein albumin. They're decreased, and that's why we have problems with our dietary or nutritional status of these patients. And also sometimes we see that fluid shift from the vascular to the cells themselves. We have a decrease in the red blood cells and hemoglobin and hematocrit, and then our platelets, and that will all affect our tissue perfusion along with our coagulation or our bleeding time. So just a quick slide here that tells you the lab changes. Diagnostics for cirrhosis include liver ultrasounds, biopsies, which would tell us the pathology and the extent of the disease, liver scans, arteriograms and portal venograms, identify the portal veins and the branches of the veins itself that let us know the patency. EGDs, and you also need to know about the nursing care related to that. I think we've mentioned it before. You need to make sure your patients have positive gag reflex prior to feeding them afterwards. And then our patients may end up having an ERCP or an endoscopic retrograde cholangiopancreatography. And that's using an endoscope to inject contrast media or dye into the sphincter of Oddi itself to take a look at the biliary tract, and it allows also for removal of stones, take biopsies, and put stents in place if needed. Nursing care for our liver biopsy in particular would be looking at our pre-procedure and our post-procedure. We do have to have an informed consent for this particular procedure. We would need to review the patient's labs, especially the coagulation panels, make sure our bleeding times were safe, educate our patients on medications to avoid prior to the procedure, and those are some of the medicines that we've already discussed prior in the presentation, like our aspirin and NSAIDs, anticoagulants, antiplatelets, and then herbal medications. And then also we want to make sure that they are NPO at least 6 hours prior to the procedure. Post-op is going to be typically like any other post-op client. We need to make sure that we're monitoring their vital signs well, especially monitoring the blood pressure on this patient. Place them in a right sideline position, and this will help stop the bleeding. It kind of puts pressure on the area of biopsy. And then monitor for bleeding, infection, and any injury adjacent to the organs. So again, you don't just want to look at the site for bleeding, you want to look below the site, and you also want to look at the skin surrounding for any abnormal bruising or bleeding. So our goal for a patient with cirrhosis is to prevent fluid accumulation and moving existing fluid collection. So some of the ways that we can do that would be through nutritional therapy and fluid balance. So our patient should be put on a low sodium diet, 1 to 2 gram restriction, avoiding all table salt, making sure that we encourage alternating flavored additives to make foods taste better. Also, we want to encourage high carbohydrate, high protein diets, and the only time we would do a low protein diet is if we had a patient that had encephalopathy or elevated ammonia levels. Then we also want to encourage small, frequent, well-balanced meals and encourage dietary supplements to maintain a proper nutrition. Drug therapy would include vitamins and supplements that are typically added to their IV fluid due to the inability for the body to store them. So things like thiamine, folate, multivitamins. We do need to avoid the fat-soluble vitamins, however, because they are broken down in the liver and we can have a buildup of them. Other things would be diuretic therapy. We want to reduce fluid accumulation. And of course, we're trying to prevent cardiac or respiratory problems that can occur. So 2 of them that may be used even in combination might be furosemide and spirulactone medications. And then remember, it's always important for us to do daily weights on our patients so that we can identify if we have an excess of gain or if our therapy is working and we have the weight loss that we're wanting. Other things listed on our slide include respiratory support. Of course, we need them to do deep breathing using incentive spirometer because if the liver's enlarged, our lungs aren't going to inflate as full, and we're much more prone to pneumonia. Maintain skin integrity. We also want to monitor neurological status. If we see any change in the LOC or behavioral changes, then that's indicative that our liver is definitely not functioning and that we need to report that to the physician. And then also monitoring their GI status. Some therapeutic procedures for our patients with cirrhosis or other liver issues might be a paracentesis. This would, of course, require an informed consent. This is so that we can drain the abdominal fluid off and get rid of that excess fluid from the peritoneal cavity, allowing for better expansion of the lungs. And also, it'll allow for us to sample the fluid to find out what is growing in the specific fluid and how to treat that. We would want to position the patient with the head of the bed elevated, check the puncture dressing site for any unusual bleeding or bruising. The patient would need to be on bed rest, and then some of these patients actually get sent home on home therapy with a Pleurax drain. The one thing that we do want to make sure that we tell our patients is that they don't want to remove more than 2,000 milliliters at one time because this causes a big, huge fluid shift and we can actually cause hypovolemic shock with that. Another thing listed here is an endoscopic variceal ligation or a sclerotherapy. This is just used to treat the bleeding. They either band or use a sclerosing procedure where they cauterize the site that is bleeding. Transjugular intrahepatic protosystem shunting or surgical bypass shunting just allows for the fluid to be shunted from the abdominal cavity into maybe the GI system to get rid of that fluid in another way so it doesn't build up inside that cavity. and then also a liver transplant may be needed. Sometimes grafting portions of the liver for regrowth may be needed, and or entire livers. So here's a case study question. A 55-year-old patient with a history of alcohol abuse spanning 10 years has been diagnosed with cirrhosis. The patient will be undergoing abdominal paracentesis on the medical unit today. Which assessment finding would alert the nurse that the paracentesis has been successful? A, decrease in post-procedure weight. B, no residual obtained during the procedure. C, substantial decrease in blood pressure. Or D, immediate sensation of a need to urinate. And you can see I have the answer here at the bottom. A, we do want to make sure that our weight is changing, that we have a decrease in our post-procedure weight. So that would be our correct answer. Next question. The patient tells the nurse that once he is discharged to home, he has no intention to stop drinking alcohol. What is appropriate nursing response? A, why do you continue to drink? B, it's your choice to drink or not. C, does it frighten you to consider quitting? Or D, if you continue to drink, you're going to die. Again, you want to think about what seems to be the most therapeutic response. A couple of these you can knock off right off the bat and know that they are not therapeutic, but your correct answer is C. You want to ask the patient about quitting because this allows them to express their feelings about drinking. We never want to demand an answer. We never want to not give recognition to the problem, and we also don't want to give advice to our patients that addresses concerns. So let's switch gears. We're going to move from cirrhosis to hepatitis. Remember, cirrhosis was a scarring of the tissue. Hepatitis is a widespread inflammation of the liver cells. So this can be caused by secondary infection, such as things like Epstein-Barr virus, herpes simplex virus, varicella or zoster virus, and cytomegalovirus. So some of the classifications, causes, and modes of transmission of hepatitis are included on this slide. They can be acute or chronic, and you'll see we have hepatitis A, which is a virus that is fecal-oral mode of transmission. Hepatitis B is blood and blood or body fluid type of transmission. Hepatitis C is also blood and body fluid transmission. Hepatitis D is a defective RNA, also from blood and body fluid. Hepatitis E is a virus that occurs from waterborne infections and or fecal oral infections. And then the book also lists non-A through E, which is just a toxic and drug-induced hepatitis, and it is secondary to infection. Pathophysiology of hepatitis is the exposure to the causative agent. The liver then becomes enlarged and congested with inflammatory cells, lymphocytes, and fluid. And as the disease progresses, the normal lobular pattern becomes distorted as a result of the widespread inflammation, necrosis, and hepatocellular regeneration. Then we see distortions increase the pressure within the portal circulation, interfering with the blood flow that goes to the hepatic lobes, and then we'll have edema in the bile channels, which will result in jaundice. Two complications of hepatitis include the filament hepatitis and the chronic hepatitis. Filament hepatitis is severe, acute, and often fatal form of hepatitis. It's a failure of the liver cells to regenerate with progression of the necrotic process. And then chronic hepatitis leads to cirrhosis and liver cancer. Health promotion and maintenance of hepatitis becomes very important. First and foremost, we want to make sure that we are vaccinating for hepatitis A and hepatitis B. I have a vaccination schedule listed on here. I'm not so interested that you know that schedule itself, but that there are options available, and many of our patients do get vaccinated at birth to begin with and then throughout their growth cycle. But if they have not had them, then yes, as an adult, we can also be vaccinated with the vaccines. The other thing we need to also think about is measures to prevent hepatitis. So that would be things like our good hand washing, our universal precautions that we are supposed to use all the time, every time on every patient. Avoid contaminated food and water. Also, receiving immunoglobulin with exposure to hepatitis A would be a health promotion. Avoid sharing personal items such as razors, razor blades, and stuff like that. The other thing would be avoiding sharing of needles for somebody who does do illicit drugs. Safe sex or abstain from sex. Cover cuts and scars with bandages or sores with bandages and make sure that we are monitoring those sites. And then do not donate blood, body organs, or any other body tissue for a patient that has known hepatitis. Signs and symptoms of hepatitis would include right upper quadrant pain, which makes sense because that's where the majority of our liver is, jaundice of the skin or sclera, and the term for jaundice in the sclera is icterus, arthralgia or myalgia, which are joint and muscle pain, diarrhea and constipation. Also, we might have a change in our urine color. It may be dark. And also our stool color, which may be more of a clay color. We could see fever, lethargy and malaise, nausea, vomiting, and also remember that pruritus or the itching of the skin. So diagnosis of a hepatitis can definitely be present in our liver enzymes or elevation of the liver enzymes like our ALT, AST, alkaline phosphate. We'll also see serum total bilirubin levels be elevated, and then we will see urine bilirubin levels also. So IgM and IgG is antibodies to detect previous or current infections that could be going on. We might also see hepatitis specific present in the blood. So I've got those listed here for you. The ELSA test tests specifically to hepatitis C. May see the OraQuick HCV rapid antibody test, liver biopsies, and also liver ultrasounds. Those are going to be some of the main things that you're going to see. And I think I missed one, and it's the RIBA, recombinant immunoblot assay confirms the hepatitis C also. Another case study question. The patient's assessment reveals yellowish discoloration of the skin and sclera. Which of the lab values would the nurse anticipate? A, increased urine bilirubin, decreased direct bilirubin. B, increased direct bilirubin, increased indirect bilirubin. C, decreased direct bilirubin, increased indirect bilirubin. Or D, increase in direct bilirubin and decrease in indirect bilirubin. That's a mouthful. So our answer actually is B. When a patient's skin is jaundiced, the lab values of indirect and direct bilirubin are increased. Urine bilirubin is also increased, and urobilinogen in the stool is normal to decrease, but the urine, it's normal to increase. So that just kind of gives you some idea of what you might see. So question, when a complete assessment of this patient is performed, what other manifestations would the nurse expect, and where to select all that apply? A, muscle twitching. B, dry skin with rash. C, personality changes. D, peripheral dependent edema. Or E, ecchymosis or spider angiomas. So according to our slide, our correct answers are B, D, and E. And I want you to remember that personality changes and muscle twitchings are findings that are seen when the patient has cirrhosis that develops with portal system encephalopathy. Additional manifestations can be found on the assessment, could include palmar erythema, clubbing of the fingernails, and fixed flexion of the fingers. So our nursing interventions for hepatitis, rest becomes very, very important. These patients need to be on bed rest to allow for the liver to rest. We need to alternate them with self-care activities and ambulation. Fat intake needs to be less than 30% of total calories, which makes sense because our liver is what produces the bile that helps break the fats down, and if our liver's not working properly, we can't break those fats down if we intake them. 1 to 2 grams of protein per kilogram of body weight, small frequent meals, over-the-counter medicines should be avoided, antiviral medications that end in VIR, and your book has several listed there, and also prevent the spread of hepatitis. So the other thing, your due-deck book has some information on the diets if you want to take a look at that also. Okay, now we're going to switch to liver cancer, which is just abnormal cell growth in the liver itself. So pathophysiology of liver cancers, we have hepatocellular carcinoma and metastatic cancers. Hepatocellular carcinomas are primary tumors in which the abnormal cancer cells begin growth in the liver itself. The cancer cells will rob the healthy cells of nutrients, and then they will continue to spread. Metastatic cancers, on the other hand, are cancers that have spread from other organs into the liver and invade the liver tissues. Causes of liver cancer: chronic hepatitis B and chronic hepatitis C can lead to cirrhosis, and cirrhosis from any cause can lead to the risk of liver cancer. So our signs and symptoms of liver cancer include patients sometimes can be asymptomatic, especially in the earlier stages. You're not going to see any changes at all. But then we may see things like weight loss and anorexia, where the patient just does not have an appetite, weakness, right upper abdominal pain, jaundice of the skin and also then of the sclera as the disease advances, bleeding tendencies, so you're going to be looking for unusual bleeding or bruising, ascites of the abdomen, so we're looking for that distension and the fullness of the abdomen. We're looking for edema in the extremities, and then also enlarged nodular liver. Liver cancer is diagnosed through a elevated serum alpha-fetoprotein. It is the tumor marker for cancers of livers, testes, and also ovaries. We can see an elevation in the alkaline phosphatase. We can also note changes on ultrasound and then CAT scan with contrast, and then of course biopsy, being able to look at that tissue and diagnose the liver cancer that way. Interventions for liver cancer would include surgical resection of part of the liver, or maybe even removal of all of the liver, a liver transplant, and your book discusses that just a little bit more also. And then we have to look at palliative care therapy, use of Plerex drains, where we are actually draining the excessive fluid that continues to build up in the abdominal cavity, selective internal radiation therapy, hepatic arterial embolization, ablation, cryotherapy, and then even chemotherapy, which could be IV or hepatic arterial infusions. Nursing care for clients with liver care is going to be supportive. Also making sure we do a lot of education, not only with the patients, but with the families. And then we have to consider end-of-life care. Again, not everybody has transplants, but we do have to think about the pre and post-transplant care. Consents always have to be signed. Education has to be provided. Making sure our patient knows how to turn, cough, and deep breathe and use their incentive spirometer. Ambulating the patient to prevent any complication with lungs, GI system, or a deep vein thrombosis. Make sure we manage their pain, but being careful there also, because we don't want to cause toxic effects to our liver. And then wound care, always having to look at our wound itself, noting if we see any redness, swelling, or drainage that might indicate infection, and then making sure the wound stays well approximated and stays clean and dry. So a few diseases that we said we were going to touch base on include the portal hypertension, ascites, and the hepatic encephalopathy. These are problems with increased arterial pressure disorders of the liver, and so they become a very critical in caring for these patients promptly. Portal hypertension is a persistent increase in pressure within the portal vein greater than 5 millimeters of mercury, results from increased resistance to or obstruction of the blood flow through the portal vein and its branches. So collateral venous circulation channels do occur. We have blood that will backflow into the spleen, which then will affect the function of the spleen. And we have veins of the esophagus, stomach, intestine, abdomen, and rectum that all become dilated, and then they have put pressure on adjacent organs and also have the chance for rupture. So some issues that are associated with portal hypertension include esophageal varices, hemorrhoids, ascites, caput medusa, gynomastia, edema of the legs, low platelet counts, and then splenomegaly and hepatomegaly. Portal hypertension is diagnosed through low platelet counts, diagnostic imaging, duplex Doppler ultrasonogram, MRI and CT. They also will do portal pressure measurements to check that pressure, and then endoscopies. It is treated with low sodium diet and diuretic therapy, a lot of times in combination with a potassium sparing and a potassium depleting, such as spironolactone and furosemide, paracentesis to drain off some of the excess fluid, and then they also may use an albumin infusion. The other thing is vasopressins that will help control bleeding, antibiotic therapy, sclerotherapy, balloon tamponading, and shunting are all different things that they may have to utilize with portal hypertension treatment. So nursing care of portal hypertension, what I want you to do is ask yourself the following. What is the worst case scenario that could happen? How would I recognize a complication? And then what would I do about it? So for instance, esophageal varices happens to be a complication of portal hypertension. Esophageal varices then can lead to GI bleed, which can lead to hypovolemia, which leads to shock and eventually death if not taken care of. Ascites, on the other hand, can lead to shallow breathing, which leads to diminished lung sounds, which leads to hypoxia. And then we end up with respiratory acidosis and can have respiratory arrest. So as you're thinking about what nursing care belongs with portal hypertension, you want to think about some of these problems that can occur. So things that we also are going to address will be daily weight, looking for any increase in weight, make sure we're managing any bleeding, monitor our vital signs for any changes in our vital signs. We're going to monitor and prevent hypovolemic shock, so we're looking for shock-like symptoms, maintain patent airway in our patients, administering oxygen as needed, use of incentive spirometer to help open up those airways. And again, one of the most important things you can do is pick up on signs and symptoms early and recognize those signs and symptoms of deterioration. Ascites is listed as one of the complications. I kind of look at it as also maybe kind of a sign and symptom that we're looking for. However, ascites in itself has so many problems, that's why it's considered a complication. It is a collection of fluid within the peritoneal cavity that caused by increased hydrostatic pressure from the portal hypertension. And so hence you see abdominal distension, which is firm, and also you can start seeing the spidery angiomas where if you look close enough you can see some of the dilated veins in the skin of the tissue on the surface of the skin. Pathophysiology. Because of the free fluid buildup within the peritoneal cavity that is made up of plasma proteins, the amount of circulating plasma proteins then in the blood is reduced. So when combined with liver inability to produce albumin and our serum colloid osmotic pressure is decreased in the circulatory system, it results in a fluid shift from the circulation to the peritoneal cavity, and that's what we call third spacing. So the end result of all of this is hypovolemia with edema that occurs. We will see massive ascites that can cause renal vasoconstriction, triggering the renin-angiotensin system, which then causes sodium and water retention, which further causes problems with edema and our weight gain and fluid overload. Portal hypertension occurs and the blood backs up from the liver and enters the esophagus and gastric veins. We'll have esophageal, or whether it's in the stomach or rectum, can happen either way. varices that occur with bleeding. Bleeding can cause a hypovolemic shock. We have slow bleeding that causes portal hypertension, gastropathy, and then our stomach's not working properly, and we have a backflow of blood into the spleen, causing splenomegaly. Platelets are destroyed, and then ultimately we have this vicious cycle that continues with bleeding and more bleeding. And this diagram just gives you an idea about how vasculature the liver is, and then our other tissues. And so if we have a backflow of the fluid, then those vessels are going to start having increased pressure in them and then have a chance for rupture. This diagram on esophageal varices just shows us how vascular our liver is. Also, you see all of the ductwork that goes from the top to the bottom, and so those issues with the varices can definitely become complications of our patients. And this picture is just a picture of how we might treat the esophageal varices with this special tube, a Seg-Stake and Blakemore tube that's placed for the emergency treatment of hemorrhage of esophageal varices. So our question is, which assessment finding requires immediate nursing intervention in a patient with severe ascites? A, confusion, B, temperature elevation, C, tachycardia of 110 beats per minute, or D, shallow respirations at 32 beats per minute. So because of our ascites that increases abdominal distension and interferes with lung expansion, compromises ventilation and oxygenation, our correct answer here is D. It has to do with our airway, of course, and so we want to make sure that we address that situation first. And again, some of the nursing care that you're going to see continue over and over with liver problems would be a daily weight, also measurement of the abdominal girth. But remember, if you have a choice between those two answers, you're always going to pick daily weight because it's going to be much more accurate. Everybody may measure the abdominal girth in a different spot, and so that would become an issue. Monitor vital signs and also use of incentive spirometer to get the lungs expanded. And then hepatic encephalopathy is another complication that we said we were going to address. It's also known as portal system encephalopathy with hepatic coma. So this is a complex cognitive syndrome that results from liver failure and cirrhosis, and it is reversible with early intervention. So our signs and symptoms that we would see would be sleep disturbances, behavioral and mental changes, speech problems, and then a late sign would include alteration in level of consciousness, impaired cognition, neuromuscular changes, and coma. And sometimes you might notice what they call a liver breath or a musty, sweet odor to the breath that's not listed on here. So the pathophysiology of hepatic encephalopathy is explained through a shunting of portal venous blood into the circulation with the liver being bypassed. As a result, substances absorbed by the intestine are not broken down and detoxified. So this leads to a metabolic abnormalities, and we have elevations of serum ammonia and then the gamma aminobutyric acid, or the GABA. Some factors that can lead to hepatic encephalopathy include high protein diet, infection, hypovolemia, hypokalemia, constipation, GI bleed, and drugs. Hepatorenal syndrome is also another complication of cirrhosis that I just want to touch base on, and it is a indication of poor prognosis with a patient that has cirrhosis and indicates the liver failure. Oliguria is one of the signs and symptoms where you're going to have severely decrease in your urine output, elevated BUN and creatinine levels with an abnormally increased urine sodium level, and then also an increased urine osmolality. So the bottom line with any of these liver disorders is we need to assess, and assess. We have to monitor our intake and output, making sure our kidneys continue to function. We need to maintain daily weight so that we can pick up on any weight gain early and identify issues there. We need to measure the abdominal girth to identify if our ascites is getting worse, teach paracentesis and or pleurex drains to our families so that they know how to care for them at home, dietary management, and get nutrition involved with that to help them keep up their nutritional intake, prevent bleeding, and also remember to report any assessment or lab changes. So just a few more things we want to touch base on, and that is surgical interventions for all of these pathologies. Pelvic exoneration is one that we're going to be talking about, and then a little bit about liver transplants. Surgical interventions include pelvic exoneration, which is a radical type of surgical treatment. It is the complete removal of body organs within the pelvic cavity secondary to the cancer. So all of the gastrointestinal, genitourinary, and the reproductive organs would be removed. So one of the things that we have to ask ourselves is, why would we need this procedure? Well, if the cancer has metastasized to the liver and the transplant is performed, we need to make sure that all of the organs that are involved that have any abnormal cell growth have been removed to give the patient the best chance for the liver transplant to be successful. So with that in mind, we have to also be thinking about diversions that are secondary to this exoneration of the pelvis. So we would have patients that had permanent colostomies and also urinary diversions. So our patients would need colostomy care and teaching regarding these two types of procedures. Liver transplant should be considered after all other alternatives have been attempted first. Liver transplants can be total liver, or they can dissect sections of the liver to be grafted to allow for regeneration and growth depending on the body's needs. The client that is not considered for transplant would be somebody that has cardiovascular instability, severe respiratory distress, metabolic tumors, or inability to follow instructions, because it's quite a process to heal from a liver transplant. A couple ethical questions I'd like to pose to you. Should the patient with alcoholic cirrhosis be a candidate for liver transplant? And should the government funds be used to care for patients with cirrhosis who continue to consume alcohol? Just a few food for thought questions. So complications of our liver transplant would include rejection and also infection. So we want to prevent rejection by giving immunosuppressant medications to our patients, antibiotics prophylactically. We're going to teach them about hypersensitivities, hypertension, nephrotoxicity, GI disturbances, and diabetes. We're also going to use strict aseptic technique when we care for them. The patients need to be taught how to do T-tube care and drain care. We're going to monitor for signs of rejection, and those would include tachycardia, fever, right upper quadrant pain, decreased bile pigment in volume, jaundice, and also lab elevation. So those are going to be our liver enzymes again, and our coag levels that are going to be elevated. And then lastly, we want to look at infection. So again, our patients are going to be compromised because of immunosuppressive therapy that we're giving. They're going to be at high risk for pneumonia because of the difficulty of the surgery it is. Also, wound infections, we need to watch for that, and urinary tract infections. Other latent infections could include tuberculosis and herpes simplex, and then also we need to think about biliary anastomosis, which is susceptible to breakdown, obstruction, and infection, which then can cause peritonitis and a whole nother problem of itself. So lots of complications can go right along with liver transplants. So a medication that we would not necessarily think of treating our patients with liver problems would be beta blockers. Beta blockers we would be looking at non-selective beta blocker agents such as propranolol that may be prescribed. And again, ask yourself why. So if we think about the increase in the venous pressure that's happening in the hepatic vein, that becomes a problem. And so we want to make sure that we are able to control that. So this medication would help by decreasing the heart rate and also decreasing that venous pressure gradient, and also to prevent any bleeding that can occur from high pressures. So tying it all together, our priority concepts include cellular regulation, infection and immunity, pain and comfort, fluid and electrolyte balance, nutrition. And so again, we always have to think, if the liver is not functioning properly, what are we going to see? We're going to have problems with infection, problems with detoxification of drugs and substances, and problems with clotting time. And don't forget the bottom line, we need to know what's in our NCLEX-RN Test Blueprint. So we have to know how to take care of our patients with liver dysfunctions and know the signs and symptoms we're going to be watching for, how to prevent problems, and also what to do about those problems.